Good afternoon, or good morning to some, good evening to others. Dear colleagues and friends, it is my great pleasure to welcome you all to this Dignity webinar on monitoring health in places of detention. My name is Jens Modvig. I'm the Medical Director of Dignity, Danish Institute Against Torture, and I'm also the chairperson of the United Nations Committee Against Torture. Dignity, founded almost 40 years ago, is an independent knowledge center working evidence-based with clinical rehabilitation of victims of torture, international projects for prevention of torture and rehabilitation, and research and knowledge development. Together with my great colleagues in the health department, whom you'll meet in a while, we are very happy to welcome you. I'm proud to say that we have received more than 125 sign-ups to the webinar. I hope you're all here, and that more than 30 countries and all regions in the world are represented. I'm also proud that we have been able to attract a very experienced high-level panel, which my colleague Lisa will introduce in a little while. The topic today is the health aspects of preventive monitoring. As we know, globally, over 11 million people are imprisoned, which is the highest number ever reported. In many countries all over the world, places of detention are of suboptimal standard, and unfortunately, treatments and conditions too often violate international human rights standards and may amount to ill treatment or even torture. Monitoring places of detention by an independent monitoring body is key to evaluate conditions and treatments in places of detention and to assess whether these are in line with international standards. It is known to be one of the most effective ways to prevent torture and ill treatment. Monitoring health is an essential component of monitoring places of detention, as the current COVID-19 pandemic has demonstrated even more. Being detained is a serious punishment in itself. Detention conditions and treatments in places of detention should not be an additional punishment on top of the deprivation of liberty. Prisoners retain their fundamental human rights, including the right to be free from torture and other cruel, inhuman, or degrading treatment or punishment, and the right to health and health care equivalent to people living in the general community. Prison authorities have a responsibility in ensuring that the right to health for all by having a well-functioning prison health service, as well as decent conditions and treatments in place. So, preventing torture and ill treatment does certainly include preventing deterioration of health during imprisonment. Such deterioration may occur due to lack of identification of health conditions upon admission, resulting in absence of treatment. It may also be due to acquiring diseases by increased transmission of contagious diseases in prisons. And it may be due to insufficient or low-quality prison health care. Further to this, prison conditions and treatment may induce health conditions such as depression, self-harm, and even attempted or completed suicide. Sometimes cases of death in custody may reflect severe deficiencies in access to health care, and in the worst cases, even death by torture. Monitoring the independent investigation of death in custody is of great importance to the prevention of torture and ill treatment. Unfortunately, the treatment and conditions for prisoners is mostly not an issue of public concern. Many people feel that these criminals have not deserved decent conditions and certainly not quality health services. In some settings, lack of access to health care is even a way to intentionally harm prisoners. Advocating for more resources to prisoners, including prison health services, is typically an uphill battle that not many politicians are willing to engage in. At the same time, prison health services are only exceptionally an attractive workplace for doctors and nurses, so the ability to recruit qualified staff is rarely there. So preventive monitoring does indeed include many topics related to health of the detainees and prisoners. We expect to elaborate this much further during the webinar. Dignity has been a part of the Danish national preventive mechanism headed by the parliamentarian ombudsman for the last 11 years. We have participated in the majority of visits, some 40 per year, undertaken by the NPM. We have been privileged to be able to gather experience about the health aspects of preventive monitoring, and we have been able to draft a manual regarding this. My colleague Brenda will provide more details about this manual, which we are launching today. So I'm pleased to hand over the floor to my colleague Brenda van den Berg.
Thank you very much, Jens, and I will share my screen. So I hope you can all see my PowerPoint slideshow now. Yes. So yeah, my name is Brenda van den Berg, and I'm a senior public health advisor in the health department in Dignity. And it is with great pleasure that I can today present to you our new manual on monitoring health in places of detention. So why this manual and for whom is it written? Well, as Jens already mentioned, monitoring health is an essential component of monitoring places of detention, with the aim to prevent torture and ill treatment. This manual aims to provide a comprehensive overview of all the prison health aspects that are relevant when monitoring places of detention and which should be taken into account before, during, and after a monitoring visit. For all these aspects, a number of questions are being answered in this manual. What is their relevance to preventive monitoring on torture and ill treatment? What do the international standards and the guidance documents say? And how could they be monitored? The manual is primarily aimed at health monitors, which refer to health professionals, for instance, medical doctors, nurses, or also public health specialists, with an interest in or an official capacity related to monitoring health in places of detention. We think that both new health monitors as well as health monitors who already conduct monitoring visits could benefit from this manual. It is important to note that the manual was mainly written with prisons in mind, but its content could also very well be applied to many other types of places of detention. Psychiatric institutions are, however, not included, as they require a quite specific monitoring approach. So this slide shows the structure of the manual. It has 6 sections. The first section provides an introduction to monitoring health, covering its aim, the preventive approach, and the role of the health monitor in the monitoring team. Section 2 focuses on the health monitoring cycle, illustrating that monitoring, including health monitoring, is not a one-off activity. It needs to be well prepared, conducted, and followed up on, and repeated on a regular basis in order to be as effective as possible. Sections 3 to 5 address all the different aspects of prison health services, prison health factors, and prisoners' health, forming the bulk of the manual. And section 6 focuses specifically on monitoring torture. Let me just briefly address what we mean by preventive monitoring of health, or health monitoring as we like to call it. Health monitoring of places of detention is the well-prepared and the regular observation and recording of health aspects and health consequences related to conditions of detention and treatments of people kept in places of detention. Preventive health monitoring looks into the conditions and the treatments affecting the health of the detainees, which breach or may develop into a breach of national and international human rights standards, all with the ultimate aim to prevent torture and ill treatment. As you saw when I presented the structure of the manual, it includes 3 key sections on respectively prison health services, prison health factors, and prisoners' health. We refer to these 3 elements as the prison health framework, where the health of the prisoners is shown at the center, and prison health services and prison health factors both impacting on prisoners' health. Section 3 of the manual outlines all the aspects on the prison health services which are relevant for a health monitor. You can see them on this slide, and I will of course not go through the full list of 14 topics, but I would just like to give you 2 examples. First, the initial medical assessment. This refers to the process of assessing the health of a detainee by a health professional as soon as possible after his or her arrival in a penitentiary institution. An initial medical assessment upon entry is key not only for the health of the examined person, but also for the health of others residing in the institution, and has as such a preventive function, for instance, when a person enters with a communicable disease. Also, the initial medical assessment is of key importance in collecting and assessing allegations and signs of torture and ill treatment that a prisoner may have experienced prior to his entry into this institution. It is a key measure in the fight against impunity and in the prevention of torture, and its importance and its purpose has been described in many international standards, among which the UN Mandela Rules. The monitor should assess the practices and the procedures in the institution with regards to the initial medical assessment, such as who conducts the assessment, is it done for all detainees, when is it done, and how is it followed up on. As a second example, let's quickly look at another topic on the list, the role of prison health professionals and dual obligation dilemmas. Health professionals working in places of detention may have conflicting obligations and responsibilities due to the circumstances of their employment and the setting they work in. We refer to this as dual obligation dilemmas, which is even more relevant when prison health professionals are employed by the prison service instead of the Ministry of Health in a country. An example is when a doctor is asked to force feed a prisoner on a hunger strike against the prisoner's will. This is never acceptable and clearly illustrates the pressure which a doctor may experience to act in the interest of the prison administration instead of adhering to his principles of medical ethics. The second element of the prison health framework is the prison health factors, addressed in section 4 of the manual. We define prison health factors as factors in a place of detention that directly or indirectly impact on the health of the people staying in that place. Prison health factors include a wide range of issues, ranging from detention conditions to treatments. The prison health factors included in the manual, they are shown on this slide. The health monitor should monitor these factors and should also look into the role of the prison health staff in assessing some of these factors, as this should be part of their job as well. For instance, checking the standards of the hygiene and the nutrition in the institution. Then the last element of the prison health framework, the prisoner's health, which is addressed in the 10 chapters in section 5 of the manual. Looking into the health status of prisoners will give the monitor indications about the conditions and the treatments in the place of detention and the health services available to the detainees both upon arrival and during their imprisonment. As an example, the monitor should look into self-harming and suicide. The monitor should, for instance, check what are the number of cases of self-harming and suicide over the last years in this institution, and assess whether this is in line with other places of detention and general trends. He should check what is done to prevent self-harming and suicide in the institution and how cases are handled when they have occurred. The final section of the manual deals with monitoring torture. It makes a categorization in physical, psychological, and sexual methods of torture, and physical, psychological, and social consequences of torture. It outlines the monitoring methodology as well as the identification and documentation of cases and their follow-up. Just a brief note about the monitoring methodology when conducting health monitoring, as we will get back to this in more detail during our panel discussion today. I just wanted to highlight that when monitoring health aspects, it is important to look into all sources of the information available. The main information sources include conducting interviews with prison management, with prisoners, prison health staff, and prison staff, making observations during the visit, and looking into documentation. For instance, prisoners' medical records, written instructions, and available registries, such as on the use of solitary confinement. The health monitor should in general not conduct medical examinations of prisoners when on a preventive monitoring visit. This should only be done in very exceptional circumstances. It is important that the information obtained from the different information sources is being triangulated, meaning that the monitor looks into 3 or more information sources on the same issue and compares the information obtained from these sources, as they may be conflicting. Triangulation will increase the credibility and the validity of monitoring results. Last but not least, I would like to acknowledge a number of persons and organizations for making this new manual a possibility. First of all, Dr. Hans Straminski-Petersen, who has been closely involved in the writing and review process. We would like to express our great gratitude to him for his valuable input to many of the chapters. Furthermore, we would like to express gratitude to the European Court on Human Rights for their extensive case descriptions on how prison conditions and treatments may amount to torture or ill treatment, and they have been used as examples throughout the manual. Also, we are thankful to the Danish Ombudsman and the Danish Institute for Human Rights for our year-long collaboration in the Danish National Preventive Mechanism. This has given us extensive experience on health monitoring, as well as practical examples, some of which are presented in the manual. We would also like to acknowledge all organizations around the world that have done important work in the areas of health in places of detention and preventive monitoring. Their work has been referenced throughout the manual. And finally, we would of course like to thank our donor, the Danish Ministry of Foreign Affairs, for its financial support. So if you are interested to receive a copy of the manual, please send us an email to healthmonitoring@dignity.dk, and the manual will be sent to your email address. You can also visit our website, www.dignity.dk, where you will be able to preview the first section of the manual. If you are interested, it will also be possible to enter into a dialogue with us on training possibilities on the manual. Currently, the manual is available only in the English language, but we will very soon have versions in Russian and French language available as well. So if you have any questions or comments in relation to what I've just presented, please do not hesitate to write it in the chat function here on Zoom, because unfortunately we do not have the time now to open the floor for questions and comments. But please do so in the chat, and this was all I wanted to share from my side. Thank you very much for listening.
Thank you very much, Brenda. And you have heard Dignity being a part of the Danish NPM on a couple of occasions. And now I'm pleased to give the floor to Dr. Marie Brasford, who will elaborate a little bit about our experience here. Marie, please.
Thank you very much, Jens. Brenda, would you mind unsharing? Thank you. I'll share my screen as well for my presentation. It's so nice to see well-known faces today, and also quite a few people that I have not met, but welcome everybody. We would, as you have heard, not have been able to write this manual without the practical experience that I and my colleagues have from health monitoring in places of detention. Before joining Dignity, I had no real idea what a prison was like on the inside, and even less idea about health in prisons, even though I considered myself a public health specialist. This is not something that I'm proud to confess, but the reality is that I'm not alone. Prison health is something that has the attention of very few professionals, and even those professionals working in prisons are not always aware of their special obligations and challenges they may face when fulfilling their duty. Monitoring health is one way to not only identify torture and ill treatment, but also to draw attention to the importance of this professional field on a broader scale. I and 3 of my medical colleagues in Dignity are members of the Danish NPM. Denmark ratified OPCAT in 2004, and in 2007 the Danish Parliamentary Ombudsman was designated as the country's NPM. In the discussions in Parliament leading up to this, the parliamentarians acknowledged the importance of supplementing the expertise of the Ombudsman with human rights and with health expertise. And it was therefore decided to add experts from the Danish Institute for Human Rights and from Dignity. That's the direct reason that I'm presenting the work of the Danish NPM today, and more specifically, the work related to monitoring health in prisons. As doctors, we participate in practically all monitoring visits carried out by the Danish NPM. In times without COVID-19, this is around 40 visits a year, of which several are to criminal justice institutions. Some are ordinary visits, in which we look into many different aspects, including health, and others are more focused thematic visits, in which we are very often able to identify a health angle. Finally, we participate in the investigation of concrete issues. A few years ago, we did a comprehensive analysis of the level of out-of-cell activities for detained individuals with mental health disorders. And you probably won't be surprised to hear that the handling of COVID-19 in prisons has been high on our agenda for the last few months. So what did we find? This short presentation won't allow me to go into the details, but I will share with you a few insights and a brief analysis of some of the changes that health monitoring may have contributed to. I will give you examples under 2 different headings: fragmentation and lack of focus from central authorities. What we have found was that there's a lack of central coordination from the Prison and Probation Service. Suffice to say that they have no health staff employed at central level, except for sometimes a part-time consultant. In practice, this means no one to make overall health-based decisions regarding the management of the prison health system. The consequences I will come back to in a few minutes. There are other examples of this lack of focus. For a few years, we have been advocating for a clearer legal framework for the handling of medicines in prisons. That is, at least a legal framework that did not contradict itself. But for a long time, this issue was not resolved. Absurdly, prison health has not even found its way into the normal health monitoring and supervision procedures in Denmark. Until very recently, the prisons have hardly ever received supervisory visits from the Patient Safety Authority. And as if that wasn't enough, the prison health staff is among the very, very few health providers in the country with no obligation to report adverse events to the patient safety database. But of course, if you don't monitor and don't receive reports, you also don't know what is happening. So in essence, what we have seen is a prison health system relying on individuals. And admittedly, many of the doctors and nurses are extremely dedicated to their jobs and do their best to fill it out. But they are forced to being lone riders, as most of them work with only a few, if any, other health colleagues. In practice, they are employed by the individual prison director and have no health professional line manager. And they do not have to meet specific requirements or go through specific training before starting their work. Just to mention one consequence frequently observed, many, if not most, of the prison health staff are not familiar with common international standards like the Nelson Mandela rules and the Istanbul Protocol, 2 of the core documents when we talk about torture and ill treatment. A lack of training could to some extent be mitigated by clinical guidelines and guidelines covering the special tasks of doctors in a prison setting. I'm thinking here of, for example, documenting violence and monitoring prisoners in solitary confinement or prisoners kept in a security cell. But without central coordination, of course, such guidelines also do not exist. Or when they do, they are specific to only one or a small group of institutions. Finally, in Denmark, all hospital doctors, general practitioners, and medical specialists are now obliged by law to keep electronic patient records. Guess where patient records are still kept on paper and with the infamous doctor's handwriting. So I hope that based on this very brief analysis, you will understand that there has been enough to talk about when looking at the health system in Danish prisons. Then, of course, the obvious question arises, does health monitoring lead to change? I would say that yes, health monitoring may lead to positive change on many levels. What we have seen is often a strong willingness at local level to change and improve. And the really good news is that over time, we have seen change at other levels as well. The NPM, of course, cannot take full credit of the changes seen, but over time and through many iterations of the monitoring cycle, including many meetings and many exchanges of letters with central authorities, we have seen improvements ranging from increased awareness and understanding to analysis and actual improvements on the ground and an improved legal framework. Let me give you some examples of positive changes and initiatives seen. In 2016, the Prison and Probation Service commissioned a comprehensive analysis of the health system in the prisons. The Prison and Probation Service is now recruiting, coordinating doctors in the 4 regions. The Patient Safety Authority performed supervisory visits in several prisons in 2019 and 2020. And on a side note, their conclusions were the same as ours, and they have the authority to issue enforcement notices, which they did. Finally, in June last year, a new law was passed in Parliament specifying the handling of medicines in the criminal justice institutions. To advocate for change, it has been of paramount importance for us to have the right tools in the toolbox. These have included thorough knowledge of international guidance and standards and of the legal framework. It has included understanding of how breaches of standards and laws may lead to or even amount to torture and ill treatment. And it has obviously included a systematic approach to monitoring, including interviewing, making observations, and reviewing documents, and providing recommendations to the relevant authorities. It's this background knowledge that we have now put in writing for others to use. On a personal note, I would say that the manual we're launching today is a document that I would have liked someone to give me when I was a new prison health monitor. The changes that we have seen may not be as fast as we would want, and the road to change has not always been a very straight one. In some areas, we may even feel that we have sometimes been walking around in circles. But we tend to believe that we have contributed to the change seen, and we certainly believe that the current initiatives in the Danish prison system will be to the benefit of the detainees. And in the end, that is, of course, what preventive monitoring is all about. Thank you very much for your attention.
Thank you very much, Marie. And I think we are now leaving the Danish context a bit and moving to the international panel. And it's my pleasure to give the floor to my colleague Lisa Mikkelsen, who will be facilitating the panel. Værsgo, Lisa.
Thank you so much, Jens. Yes, and it's true. Now we're moving forward to the panel discussion on how to monitor health in places of detention and its key challenges. Thank you so much, Marie, for already sharing some practical experience with us from the Danish NPM. I think many of us can relate to your description of prison health systems that rely on individuals. I am, as Jens and Marie also has mentioned, very excited to see so many people from around the world joining us today. And I'm very honored to present to you the expert panel we have with us today. And dear panelists, thank you so much for taking the time from your busy schedule to share your knowledge and practical experience from your work with national and international monitoring bodies and networks. I have seen everyone from the panel today, but I haven't seen Dr. Benito Mulino. Are you here?
Yeah, I'm here.
Perfect. Thank you so much. I will now present the panel we have with us today and start with Dr. Homer Ventus, Clinical Associate Professor at New York University College of Global Public Health and former Chief Medical Officer of New York City Correctional Health Services. We also have Mr. Stephen Caruana, Coordinator at Australia OPCAP Network and Senior Quality Assessor at Quality Assessment and Monitoring Group. Dr. Alan Mitchell, General Medical Practitioner at Dungival House Immigration Removal Centre, Commissioner at Scottish Human Rights Commission, Chair of Independent Prison Monitoring Advisory Group Scotland, and member of CPT, European Committee for the Prevention of Torture. Dr. Benito Mulino, Forensic Medical Consultant at the Medical Action Group and Belay Rehabilitation Center, and member of the Philippine Interim NPM, and Dr. Marie Brasford, Senior Medical Officer at Dignity, member of the Danish NPM, and member of SPT, Subcommittee on Prevention of Torture. I will now give the floor to the panelists to share with us your reflections on how to monitor health in places of detention and what you consider the key challenges in this work. Afterwards, I will open the floor for participants to ask questions to the panel. So you can already write down and prepare your questions. I will also take on the not so funny task as being the timekeeper and let you know when you have 1 minute left to wrap up. You will each have 5 minutes in the panel for your presentation. And I will kindly ask you, Dr. Homer Ventus, if you would like to open the panel. Thank you.
Thank you. Thank you to everybody for the invitation. Let me know if you can't hear me, but I'm thrilled to be part of this group. Are you able to hear me okay?
It's a bit low here.
Okay, I'll try and speak a little bit louder.
That's perfect.
I'm in a hotel room in the rural south of the United States in the middle of doing prison inspections for COVID. So hello, I'm a correctional health doctor. I about 8 months ago or 10 months ago left my position running a small nonprofit to focus exclusively on COVID inspections and COVID work in prisons and jails and immigration detention in the United States, and have done about 30 physical inspections of these facilities in the past year. And I really am thrilled and honored to be with you all. I want to really commend Dignity and the partners for the manual that I'm just so excited to see and review and support. I'm coming to you from a country that is lacking in two important elements that many of you have to use on behalf of people who are incarcerated. One is the involvement of legitimate health authorities, departments of health, ministries of health in promoting health among incarcerated people. And the other is a culture and practice of monitoring. Both of those things are lacking in most of the 5,000 jails and prisons and immigration detention centers in our country. Having said that, we still have methods by which we can conduct monitoring. And what I would pass along are two very basic observations from this past year where this is all I've done. The first is that monitoring has become much, much more important since the onset of COVID-19. Obviously, people are getting sick and dying from COVID-19. In our country, about 20% of prisoners have contracted COVID-19 with thousands of deaths, and that number, 20%, is a gross undercount. Similar for jails, pretrial detention and immigration detention. But people are getting sick. But the other important and less observed problem is that many of the baseline failures of correctional health services have really been torn apart even further from adequacy. So the ability to seek care when somebody becomes sick is less possible now that there are fewer staff working because they're sick. now that facilities are on lockdown so that people cannot move to health staff or health services as adequately as they need. Many correctional staff have become sick, many have died. And what I'm seeing now, 10 months into this outbreak, is that some of the evidence-based infection control practices that were imposed or implemented in May and June and July, those now are coming apart because these aren't places with a culture of infection control. They're not places with a culture of evidence-based healthcare often. And so many facilities made some effort to implement some basic responses, and those are kind of falling prey to what I would classify as COVID fatigue behind bars. And so things are actually getting worse as I do more and more inspections. Access to specialty care outside specialists has been essentially blocked during this time. So people who needed diagnosis for cancer or other serious health problems really aren't getting it. And I'll just finish up because I see I've got about 45 seconds, is that it's more important to do monitoring than ever, but it's also very feasible. Many times when I go in, the facilities will try and block my access by saying, I'm going to cause a super spreader event, or monitoring is part of spreading the infection. That's completely false. There are very good and practical ways to use PPE to plan the path of an inspection during COVID-19. And we've been able to convince courts and judges of this over and over. So it's very possible to conduct these inspections. And I guess I would just end with, it's more important than ever for people who are incarcerated that outside eyes come in to assess health and health quality. Thank you.
Thank you so much, Dr. Homer-Vences. I am very sad both to see and hear what COVID-19 has done to both prisons and prisoners in your country. But I'm glad to hear that you are monitoring and you're spreading the words about how important this is, especially during this pandemic. Thank you so much. And I will now give the floor to the next panelist, Mr. Stephen Caruana.
Thank you. Can you hear me?
Yes.
Great. First of all, I'd like to acknowledge the traditional custodians, the Darug people on whose lands I am joining you today. I acknowledge their elders, past, present, and emerging. I'd like to also thank Dignity for the opportunity to speak among such distinguished panelists and friends. So being the only non-doctor on today's panel is admittedly quite daunting. I had to ask myself several times, what did I have to contribute to this discussion? And as I reflected on it, I looked over my experiences of monitoring detention as a non-medical expert and remembered that on many visits, although not ideal, the monitoring body I had been working for did not always have the luxury of medical experts on their team. Yet health was still an important area that required assessment in some form or another. Non-medical experts on a monitoring team may, for obvious reasons, be reluctant to look at health, preferring instead to defer that part of the work to the medical experts. Of course, for anyone who is not medically trained, it may seem impossible to assess, for example, whether a place of detention is offering health care equivalent to that of the community. Trying to make sense of medical terminology or questioning physicians on their decisions may seem unappealing. However, this mindset is a hindrance to a non-medical expert's growth. You see, in almost every case of monitoring I have undertaken, I have invariably had to have discussions around health with detainees and staff alike. In some cases, such as monitoring psychiatric units, I have found consumers less likely to speak to my medical colleagues because they speak too much like their own physicians. In other cases, I've asked medical staff the important questions to gauge how well they can explain difficult medical concepts in plain language. After all, if I don't understand it, it may be likely their patients don't either. I'm a firm believer that all monitors should have these discussions and welcome them to gain a fuller understanding of the environments in which they monitor. Did I, for example, think a few years ago I would be able to comprehend wound charting or understand what non-pharmacological interventions could be tried for a detainee with dementia? No. but these are skills I have picked up working side by side with medical experts in a monitoring team. The Association for the Prevention of Torture notes in its detention monitoring guidance that where medical personnel are not available, the team members must take care to request general information on the state of health of persons deprived of their liberty, the most frequent illnesses, detection of transmissible and contagious diseases, and death. They should also examine the system for gaining access to medical care. And in adding to this, the International Committee of the Red Cross, in its monitoring guidance, introduces the concept of the health pyramid as a useful prompt for teams assessing detention health. Following this model, a healthy environment has at its base adequate food and nutrition, adequate hygiene and sanitation, and appropriate accommodation. Adding to the base, measures for the protection and promotion of health must be undertaken. And finally, a curative approach at the peak of the pyramid is the part of the system for sustaining overall health. Supporting the health pyramid at every level are psychosocial factors, which are the less obvious and sometimes invisible influences on health, such as internal and informal hierarchies and detention routines. These are, of course, the everyday factors that non-medical monitors assess in their day-to-day role, and should not therefore seem the daunting task they appear to be. In fact, in some instances, a non-medical expert may be more appropriately skilled at looking at the context in which help is provided than the actual medical experts. To give you an example, I was once asked to participate on a visit to a prison hospital where we were looking at the provision of mental health care. The visiting team had gone to the hospital 3 months in a row and were concerned about increasing restraint and seclusion incidents. The team was made up of a psychiatrist, nurses, and a general practitioner. They had explained to me that they had spoken to medical staff on numerous occasions, made recommendations about diversionary activities and trauma-informed practice, and still could not understand why incidents kept increasing. As we undertook the visit, the team went about its usual business of talking to detainees and medical staff. I noticed that no one spoke to the correctional officers. As I spoke to officers about how difficult behavior was managed, it became apparent to me the influence of correctional officers over medical staff. Whilst healthcare and corrections were separate entities, if a medical officer did not comply with the order of a correctional officer, they could face expulsion from the site for disturbing the good order of the prison. This problem, Dr. Homer Venters describes as the concept of dual loyalty, where an often contradictory allegiance is formed by medical professionals between their patients and the security dictates of the detention environment. For fear of losing their jobs, the medical staff did not speak up about it, but some of the corrections officers wore it as a badge of honor, noting that if anyone played up, they decided if they would be chemically restrained or secluded. Now, it may seem a pretty extreme example, but it does show how sometimes your expertise may hinder you from seeing the forest from the trees and missing something critical about the wider context of health delivery. Thank you.
Thank you, Mr. Stephen Cariana. And also thank you for sharing the very useful points of how non-medical staff can complement health monitors by looking at a wider context. As you have already mentioned, the reality in many places around the world, many places of detention, is that health expertise is not always a part of the monitoring team, unfortunately, as you mentioned. And I'm very glad that you're highlighting this. And I think also your practical example is very illustrative and reflects reality for us people who have been in prisons or work in prisons. So thank you very much for sharing that. And then I will go to the next panelist, Dr. Alan Mitchell. Thank you.
Lisa, thank you very much. I hope you can both see me and hear me.
Yes, very clearly.
Thank you. I have the honour of following Stephen and Homer in the remarks that I have to make, and as they were giving their presentations, I was quickly reannotating my own speaking notes in order that I didn't replicate what they had said, and I was struck with a remark that Stephen made, and that is about the importance of speaking to correctional officers. and in the context of the monitoring of health. And I'm going to plug Homer Venter's book here, Life and Death in Rikers Island. When I realised Homer was a panellist, a fellow panellist, I thought I better read this book, which has been recently published. And in his book, Homer clearly sets out that incarceration itself increases the risk of death. In his presentation, Homer spoke about COVID and the risks associated with COVID and the importance of maintaining impersonal, physical, on-site monitoring. I join you today in part as a member of the European Committee for the Prevention of Torture. Since the beginning of the COVID pandemic, the CPT has maintained its on-site, in-person monitoring. Since March of last year, we have completed 13 visits to member states across the Council of Europe area. 5 of those were already planned periodic visits, and 8 of the visits were ad hoc. They were judged to be necessary in the circumstances. We undertook a very COVID-specific visit to France, and we visited Greece and Croatia and Malta in the context of immigration detention to find out what challenges those who are confined administratively face in the context of the current COVID pandemic. We also went to Bulgaria, where we looked at social care and psychiatric settings. It's already been mentioned that appropriate steps can easily be taken to mitigate the risks of in-person visiting and monitoring. And I feel very strongly that in-person monitoring is as important in places of incarceration. The presence of monitors in person is as important as the presence of discipline staff, security staff, and healthcare staff in person within those settings. Jens, in his introduction, mentioned that it is essential that we take all steps possible to prevent the deterioration of health associated with imprisonment. What we have seen during the COVID pandemic is that places of detention are locked down. Prisoners in particular are often confined to their cells for prolonged periods of time. They do not have, or are not often afforded, access to outdoor exercise, to communication with family and friends, to showers, and the ability to interact and engage with others, each of which is a fundamental right. And indeed, the CPT on the 20th of March, we published our statement of principles for places of detention in the European region, designed very much to highlight to prison administrations and governmental authorities of the importance of the maintenance of these fundamental rights of persons who are incarcerated, including access to healthcare services. I was privileged that I was given an advanced copy of the Dignity Manual yesterday, and I note with gladness the section on monitoring healthcare services and then monitoring the environmental impacts of health within custodial settings, because it's both the environmental impacts and the provision of healthcare services themselves that have a very direct determination on health outcome. So thank you very much, Lisa. I hope I've stuck to my time and look forward to the contribution of the other panelists. Thank you.
Thank you so much. You are a very decent panel. You're all keeping your time. It's very easy for me. Thank you so much, Dr. Alan Mitchell, to share this with us. I think it's quite impressive to hear about CPT and the continuous visits you are able to conduct during this pandemic. I think we are all struggling in these times to find out how to get access and continue the important monitoring during this COVID-19 pandemic. And thank you also for showing Home Aventis' book. I think it's kind of a Bible for most of us working in this area. For you who haven't read it, I will really recommend it. Now I will move on to the next panelist, Dr. Benito Mulino, and give the floor to you.
Yeah, thank you. Good afternoon, good evening, good morning to everyone. And thank you for the invite. And I also would like to extend my thankful to my colleagues in the Philippines. Well, health monitoring to begin with, I would like to say that health monitoring in developing countries like the Philippines is very challenging because the situation is very alarming. Very alarming is that because as of now, of our population of 110 million, one out of every 500 is a PDL. That's one out of every 500 population is a PDL. And our PODs, place of detentions, is 4 to 8 times congested. And before the pandemic, this is already the situation because of the war against the drug by our president, wherein police officers or police in operations have a quota to arrest number of persons in every operations. And this quota system congested the jails. Now, and when pandemic came, most of people arrested are now under the police custody. So the holding areas of the police, the arresting officers, became place of detention for months. So when the pandemic started in the Philippines in March, until now, those people arrested in March are still waiting to be committed to regular jails. So that is the very bad situation regarding our jails in the Philippines. And making it worse, the health personnel attending those people is very, the ratio is very high. For a doctor to PDL ratio, we have around, for doctors, we have 1 to every 11,000 PDLs. And for nurses, we have around 1 to 200 nurses. And we have very few psychiatrists or psychologists in our in the health services providing health to PDLs. So because of this condition, with the coming of the pandemic, our congested jails it's like a time bomb. Actually, since the pandemic, at least 15 deaths were registered because of the virus. And the other health conditions is very alarming because the supply of medicines, the visits of civil society organizations are being prevented in going to jails. So we were left with online medical consultations, online monitoring, and yet some of the jail under BJMP refused our services because of the now prevailing red tagging in the Philippines, wherein organizations attending to the needs of the impoverished, of the minorities or political prisoners are being linked or are being targeted or branded as communists and enemies of the state. So that's another factor that preventing us from doing our monitoring into to health facility, to jail facilities. So with these conditions, with the lack of drugs, lack of health personnel, lack of psychological support, our PDLs are really in very difficult conditions, as well as the relatives who are prevented from visiting these PDLs. So, but we have to be creative in doing monitoring. So we make use of our contacts inside prisons, media, as well as friendly jail officers. So because of this, we were able to provide health services, as well as document conditions that making our PDLs difficult in these times. So the challenges continue. As I said a while ago, the district tagging, the refusal of some officers, of jail officers, because of this government war against drugs and the perceived enemies of the state, and the lack of human resources as well as financial resources. These are all conditions that are preventing us from doing our regular monitoring of the health conditions and documenting cases of torture and other ill treatment inside prisons. So that's all. Thank you for the time.
Thank you so much. I can hear from you, as from the other panelists, that COVID-19 is very much affecting our work these days, of course. It sounds like it's a very challenging situation you have in the Philippines, and I think all what you're mentioning is like lack of staff and a pandemic, overcrowding, a non-supply of medication. Sounds like a big crisis for the health in prisons. And I noted that you say you have to be creative and innovative in this period, and I think that is very the key words for us in this field, especially when we're facing a pandemic and lack of access. So I'm glad to hear that you are sharing this very challenging situation you are in right now. I will then move to the last panelist, Dr. Marie Brasford, and give you the floor.
Thank you, Lisa. I think the panelists so far have clearly demonstrated how varied monitoring health can be and what types of different challenges we may face. And what I'm saying or going to say is something that relates a bit with what Stephen Caruana talked about, because I will reflect a bit on the role of the health professional as a monitor. Being a health professional and a health monitor means that you're expected to be deeply familiar with the aspects that you're monitoring. And that is indeed often the case. You're used to people being patients. You're used to handling informed consent, and doing no harm is something that you have heard about from day one in medical school or nursing school. You're also used to handling and caring for people who are at their most vulnerable and who sometimes are being difficult to handle because they're anxious, aggressive, depressed, scared, or even psychotic. All this implicit and explicit knowledge pertaining to your profession equips you well to monitor prison health. And there are a lot of things that you will immediately notice while spending time in a prison. You'll see the sick prisoners, their bruises, the quality of the medical records, and the lack of the same, the outdated prescription medicines, the lack of equipment, etc. The specific professional skills can also be used in the monitoring team when looking at other aspects of prison life. For example, as a doctor, I'm trained in interviewing techniques, and I have been asked to join interviews of detainees who were envisioned to be particularly difficult to interview, due, for example, to them having a mental health or cognitive problem. A health professional may also be able to broaden the scope of monitoring other aspects of prison life and may come up with questions that would otherwise not be asked, thereby enriching the information provided to the monitoring team. And it's a bit what Stephen already talked about. But being a health professional on a monitoring team comes with its challenges as well. Working in a multidisciplinary team is challenging for everybody, but sometimes you as a health professional are the only one who actually embodies the multi in the otherwise unidisciplinary team, because you'll find yourself as the only health professional in a group of lawyers. This in turn means that sometimes you need to struggle to make health get the focus, the time, and the attention that you believe it merits. There are usually many issues to cover in a monitoring visit, and health is just one of them. If I should positively reframe another one of the challenges, it is that being among members of another professional group is a huge learning opportunity. There's a lot that health professionals can learn from lawyers: a different language, a different focus, even a different set of principles, where I have learned that sometimes the law may want to overrule my beloved do no harm principle. Sometimes all those things can really bring you out of your comfort zone. And speaking of comfort zones, the last thing I want to mention for now is that even for health professionals, monitoring health in prisons can sometimes be well outside of their comfort zone. The reality in monitoring teams is that health monitors come in many different shapes. They may be nurses, psychologists, ophthalmologists, cardiologists, gastroenterologists, psychiatrists, surgeons, ear, nose, and throat specialists, and many others. No matter their specialization, though, monitoring prison health requires them to move out of their comfort zone and into areas that they have maybe not dealt with for many, many years, if ever. Add to that monitoring is rarely a full-time occupation, but something that the health monitors do beside their ordinary jobs. Last, but certainly not least, health monitors are required to shift their focus from the clinical to the public health paradigm. This is not an easy shift to make, but it is when a health monitor succeeds in doing so that preventive health monitoring is really being done. Thank you.
Thank you so much, Marie, and also for keeping time. Thank you for sharing your reflections on the role of the health monitor, which I agree can be very complex and also get you out of your comfort zone, but also includes many of the skills that healthcare professionals already have acquired, and we should remember to use them. I especially found your point about shifting from the clinical paradigm to the public health paradigm to succeed as a health monitor, a very important point. I will now open the floor for questions to the panelists from participants. So please feel free to raise your hand to indicate if you have a question. Then I will give you the floor. You can raise your hand in Zoom, as Marie Louise have already mentioned, by clicking on participants and then on the raise your hand button on the lower right corner on your screen. This Q&A session will last for 15 minutes and maybe a little bit more because we have a little more time. And yeah, I hope you have some questions out there that you would like to share with the great expert panel we have with us today. I cannot see anyone who has raised their hands yet. So I can maybe use the opportunity while you think about your questions or prepare them to use this very privileged opportunity I have and ask a question myself. I think if NPM, one thing I have been thinking about with this manual, which is very huge and long, and health monitors is many things. If NPMs or other monitoring bodies wish to focus more on monitoring health, where should they start? And what areas should they prioritize? For example, the manual is very long and covers many aspects, but all aspects cannot be monitored in every visit. So what is your view on that? Is there someone in the panel who would like to answer that question?
Lisa, Alan showed that he wanted to speak.
Okay. I can only see that now. Yes, go ahead, Alan. Thank you so much.
Thanks, Lisa. I would always suggest starting with the director or the governor of the prison or the immigration centre. Prison directors, prison governors have a responsibility for the safe custody, but also for the health and welfare of those whom they are charged with. And in my experience, prison directors, managers, and governors have a pretty good idea, generally speaking, as to what the challenges are within their own particular establishments. Previous speakers have touched on the lack of coordination of prison healthcare services and the lack of involvement of central authorities. I think it was Jens that touched on that, and he spoke about prisons not really being attractive places of work for doctors and nurses. Marie referenced prison healthcare systems relying on individuals. And I think my own experience is that prison managers, directors, governors have a reasonably good idea as to what the challenges are within their own establishment. And that's something that certainly in the CPT we do when we visit an establishment. We talk to the prison governor before we speak to the healthcare staff and the prisoners. And also mention has been made about speaking to the staff. I think sometimes monitoring bodies, we're seen as a threat rather than an opportunity. And certainly my practice increasingly has been to spend an increased amount of time listening to the staff on the prison wings to hear what their concerns are, because they will invariably have a good idea as to what life is like within that particular establishment. Thank you.
Thank you so much, Alan. I think that was a very good point. I can see that we have two questions in the audience, one from June. I will give you the floor. If you turn off your microphone, you're still muted. It's
okay.
Yes.
Good evening for me here in Manila. Thank you very much for the invitation, and congratulations to Dignity for this very important document that you have published and made available for many of us. My question is related to presentation of my Philippine colleague, Dr. Mulino. Given the situation that he shared, does creativity include training even non-health staff, particularly POD staff, not necessarily health professionals or healthcare workers, for paramedic care, first aid, and basic knowledge about COVID prevention. The factor of lack of competent human resource is very real for the developing world. And, but I see that there doesn't seem to be a consensus about this. Early in the months of COVID, the beginnings of COVID, the interim NPM of the Philippines precisely did this because we were prevented. We were not allowed to enter places of detention. So we decided to find a clever, creative way, if you must say, to have access into jails by offering, first of all, PPEs to frontliners in these places of detention, as well as training on basic COVID care for PDLs. But that doesn't seem to be something that many international organizations, even NPMC, as being part of their mandate. So I would like to get some opinion about this.
Marie?
Thank you for the question, June. I don't know if it is part of the mandate of an NPM to train people deprived of their liberty to handle coronavirus. But what I can share with you is that...
Sorry, Marie, it's not the prisoners, but prison staff.
Good. That's exactly what I wanted to talk about now. So that fits perfectly. Because actually in Dignity, I want to share with you the experience that in Dignity we have developed a training program for prison staff. And that's a training program that is not only for health staff, but also for security staff and for management. We started off in Sierra Leone with a training that we developed, and the training was provided by our partner in Sierra Leone. And they started by training the prison staff, and eventually they came back and said that it was necessary, for obvious reasons, to also train the prison management, because otherwise it was too difficult for the staff to do what they by then knew to do. And we have rolled out this program in other places of the world as well. So we have worked in Moldova, we have worked in Zambia, and actually also a tiny little bit in Mindanao in the Philippines, where we did a brief online training for some prison staff. So I think there's definitely a lot to be gained from involving not only the health staff, but everybody. And what we saw, particularly in the Philippines, was that the staff was very grateful to get some basic knowledge about the virus, because they actually did not have it. So the training was not only for them to be able to do their duties, so to speak, but also for them to feel safe when they went to work.
Thank you very much for that.
Thank you, Marie. And I have the next question from the participants. It's from Dr. Livingstone Sewanyana. Are you there?
Hello, Lisa.
Hello.
Okay, I'm here in Kampala, Uganda. Of course, you must be aware that tomorrow we are going to elect our president and also members of parliament. So our prayers for us. It has been a fairly difficult moment. But speaking about the manual, I want to commend Dignity for such a wonderful work. I'm sure that the manual presents an opportunity to all those who are engaged in monitoring prisons to pick up some lessons, but also guidance. My major challenge is that for the last 20 years, we have been inspecting prisons in Uganda as the Foundation for Human Rights Initiative. It's one of our major activities. But ever since the outbreak of COVID-19, there has been a big issue of access. the prison administration does not allow people from outside to access the prisons. And as such, it's becoming increasingly difficult to assess the health conditions of inmates. So I would like to find out from Maria and others, how do you deal with this question of access during COVID-19? How do you find your way? How do you, make a case for health inspection, considering the fact that there is a lot of fear from the prison administration that those people coming from out could easily, of course, infect prisoners, and it is a big issue. The prisons now increasingly, I would say, are now closed institutions. You can hardly access them, which makes even health inspection or health monitoring almost impossible.
Thank you, Dr. Livingstone, for that question. I think maybe Homer Ventus, do you want to reply on that? You are very much in that situation, maybe not in that situation, but in that environment right now.
It's great to hear from you from Kampala. It takes me back to time when I worked in Kasoro, but I think that most facilities will object here in the United States to outside inspections because we don't have a culture and a practice of this. They often use this infection control argument. Most of the time it gets set aside, but in 2 or 3 cases I've had to go to court and testify. And what has been effective in those cases is to show the precautions and preparation and protocols of the outside monitors, myself and the team, what we're going to do step by step, all the precautions we're going to take, and then compare that to what actually happens every day in the facility. And so every day in the facility, the staff come and go. They often come and go without any type of screening. They often move from building to building using the same gloves or no PPE. And so what we've had to do in all 3 or 4 of the cases where this has been a real fight is show our very precise preparations and protocols and compare that to the daily realities of staff who go into the facilities right now. And, in the few cases where that's happened, we've been able to prevail because it's been clear to a judge that, our measures are not introducing more risk and the current practices really do promote risk.
Thank you so much, Homer Ventus. I hope that answered your question, Dr. Livingstone. Yeah?
Yes, indeed. Thank you.
I have some more participants who have questions, and the next on my list is Hamad Mohammed.
Yes.
Yeah.
Hello. Yeah,
hello.
I can hear you. Thank you so much for Dignity and the panelists. I think it's a very good webinar, and the panelists had a lot of experiences to share. So it's not really a question, or rather a question and a comment. My comment, I work with my name is Mohammed Hamad, and I work with the WHO Regional Office for Europe in the Health in Prisons program. And although it's located in the regional office for Europe, but it has a global perspective, maybe the only program that has located in the regional office, but it has a more look at globally at the health in prisons. So early in the pandemic, we developed this very simple tool. It's a survey meant for prison authorities or a national authority that represents officially the prison administration or department or health department within the prison, to share with us basic prison population figures and epidemiological findings about COVID-19. So very simple questions like how many people living in prisons have been confirmed to contract or to have COVID-19, how many of them are older than the 50 years old, how many deaths were related to that inside the prisons, and how many prison staff, for example, were also infected. So we were able to, a lot of countries were able to share with us on a regular basis, and we also asked the countries to update this information on a weekly basis if possible, or bi-weekly if it's not possible on a weekly basis. And what we do with this data is, one, we after several submissions from a particular country, we come back to them doing a little bit of analysis and informational charts and a summary of their submissions to make it more visible and clear for them if they want to make a policy or decision making based on that charts or summary. And we also, after monitoring, we capture, or we take notice of countries that the epidemiological situations is extremely, the incidence is extremely higher than the general community in that country, and we offer them if they need any technical support, and we sometimes a country reach out for us for virtual missions, for example, and we have been successful to do that with several countries in the European region. So I was just sharing that with you to, as we're talking about monitoring. I think that's a very good tool to be able to monitor the situations in prisons. And also, I know that there are a lot of participants now. Maybe some of you may be interested in sharing this link for national authorities to share with us their updated situation. My second question, and I'm sorry to take a long time, is that the new developed manual, that the Dignity Manual, will that be also applicable in closed settings? So there is the prisons, there is the youth detention centers, there is the immigration detention centers, but there is also closed settings that are not in the spotlight, like military camps or police camps. And these have a lot in common. The environment there has a lot in common with detention centers and other places of detention. Will that manual also can be used in those settings? Thank you, and sorry again for being too long.
I thank you for the questions and also sharing the tool you have developed in WHO. I have read it and used it, and I found it very useful. I think maybe Brenda can reply your question.
Yes, I can just mention that, like I said in my presentation, that it has been written with prisons in mind, but a lot of the topics that are addressed in the manual, of course, also apply to other detention centers and facilities, and including like military camps and, like you mentioned, closed centers. So it will definitely be useful.
I have now not many minutes left, and I only have one participant who has raised the hand, and it's Eve Lester, and that would be the last question for this section. So please, Eve, if you turn off your microphone, I will give you the floor. Are you there? Not. Okay, I have some, yeah, there you are. I can't hear you. You're still mute to me. I don't know if you can change your settings. I cannot hear you still. I can see you talking. Maybe it's the headphones. Sorry, Eve, I will leave you to try and solve this, and I will take a question from the chat, or else you can write your question in the chat and I will take it. Okay, while we're waiting for Eve, we can take, I think that's the only question we have time to actually. Okay, I can see Ellen Mitchell. Yeah, I just need to There should be a question from Homer Ventus that Alan is asking me to ask.
No, it's from Malcolm Evans.
It's from Malcolm Evans.
I can just read it out, Lisa, if you want me to.
Thank you so much.
Yes. It says, I was wondering what panel members think what might usually be done remotely in those situations where access simply cannot be achieved.
Is there anyone from the panel who would like to answer that question? Alan, is that a hand? Yeah, there you go.
Thanks, Lisa. That is a hand. I think that's a very appropriate and an incredibly challenging question from Sir Malcolm. I chair the Independent Prison Monitoring Advisory Group in Scotland, and that group has recently moved to remote monitoring only. The remote monitoring is by way of telephone calls to the prison director, to a senior officer within the prison, and also by the monitors identifying certain prisoners that they would like to speak to. Identifying them by way of their cell location rather than their names. And as has been said during a number of presentations, in COVID times, prisoners tend to be locked in their cells for far greater periods of time. And what we have found is that when we have had our monitors speak to prisoners, the prisoners with whom they are able to speak invariably are the prisoners who are enjoying some out of cell time. They are prisoners who are working perhaps as cleaners, they're working in the kitchens. And as such, that particular group of prisoners probably have a more positive view to report on what life is like within the prison than those prisoners who are confined to their cells, and particularly those prisoners who are confined to their cells for reasons of COVID isolation. And that's one of the reasons why in the CPT we really have continued with our visits and pressed to have our visits in person and on site, because I think remote monitoring can tell us a little. It may actually falsely reassure us in part, but I think there's nothing quite can substitute for monitoring in person, though I absolutely accept there are significant challenges. Our colleague from Kampala asked, here is the issue of resistance, and I think what we as monitors need to be setting out is that we come here in order to give our advice, our overview, and how we can, how this prison can be made safer for both those who live in prison and those who work in prison during the current pandemic. So I think monitors have a useful role in approaching prisons, particularly in these COVID times, as critical friends of prisoners, but also critical friends of prison staff. So I hope that's helpful.
Thank you very much, Alan Mitchell. I very much agreed with what you're saying. I have to close the session now, so we cannot take any more questions. I will say thank you for all your questions, and also again, thank you to the expert panel for sharing your knowledge in this very important field. I have learned a lot today, and I think what we can take home from this is how useful it is to share knowledge with each other across borders to be able to stay updated and innovative. So I think the key message, in my opinion, is for us to remember to reach out to each other. And then I will give the floor back to Jens Modvig. Thank you.
Thank you very much, Lisa. I think this has been a very interesting discussion. We have mainly touched on two issues, and I think we could probably have found out in advance that these would be the issues. One is the COVID-19 and the impact on monitoring. And when we hear that in certain countries, we have heard that before, that monitoring is prohibited by the authorities, of course, what becomes important here is the legal mandate of the monitoring bodies, if there is in fact a legal basis for insisting on the monitoring. The second issue, I just want to mention here that Dignity has actually developed a curriculum on monitoring during the pandemic and what can be done and what are the considerations. We have implemented that curriculum, and if some of the participants are interested, we could perhaps discuss whether it could be implemented there. The second one is the relationship between the role of the health professional and the non-health professionals. And some raise the issue, what if we don't have a doctor at all? Others say, well, we can maybe get a health professional on an ad hoc basis. But of course, the ideal situation from our point of view would be that there's integrated health professional expertise in the monitoring generally, and that both non-health professionals can address health issues, as Stephen Caruana mentioned, and also that health professional monitors are competent general monitors. Nevertheless, I think that the manual we have drafted can be useful also to non-health professional monitors, and maybe provide some guidance if health focus should nevertheless be a part of the monitoring team. I would like to end by extending my gratitude to the panelists for their valuable contributions. Homer, Stephen, Alan, Ben, and Marie, thank you so much. I believe, as Lisa, we learned a lot. Also, thank you very much to all the participants for being with us today. I hope that many of you will reach out to us to discuss collaboration on training or perhaps other ways of collaborating. And finally, thanks to my dear colleagues in the health department for their highly professional performance today and any other day. It's always a pleasure to work with you. And by this, I would like to say thank you and goodbye.